place. So I'm going to just, this is going through some x-rays here. This case was or is a 16-year-old girl who was a gymnast, and she sustained an injury at her L5-S1 level. She had a bilateral pars fracture, and she underwent an extensive amount of conservative therapy, wore a brace for a while, but continued to remain symptomatic with primarily back and some leg symptoms. So she was referred in, and I performed an L5-S1 instrumented lumbar fusion, which was carried out on a same-day basis. It was home by 5 o'clock, and this was carried out back in March. And she's back to school. She's swimming. She's pain-free. But the first slide shows the positioning of the initial instrument, and with the technique involves initially inserting a needle. It's an 18-gauge 10-inch needle that goes down. It's into the disc space. Again, relocate it fluoroscopically, and contrast with indigo color will be injected. And you may be looking at this thinking, where's the spondy? But this was the correction on the table. Before she got on, there was a grade 1, grade 2 spondylolisthesis. This is the sheath, the working sheath that is advanced down over the stylet and over a dilator, and it accesses the posterolateral margin of the disc space. And the decompression and the preparation of the end plates is carried out in a biportal fashion. And one of the things with the MIS and the percutaneous approach, and some of the initial concerns were, are we able to carry out the surgery as effectively as an open procedure? And with the video endoscopic technology, and in this particular case a biportal approach, we absolutely are. We're able to evacuate about 75 to 80% of the disc material in the space, prepare the end plates adequately to give fusion the best chance. And there are specialized instruments, again, that have been developed that allow us to go down this 8mm portal. And this instrument is called a shaper, and it's one of the instruments we use essentially for decompression and roughing up of the end plates. Once we've decompressed the space, one of the things we want to know is, have we taken out enough disc material? We haven't left any fragments there. So we use this balloon device. It's basically like a glorified angiocath, and it's inserted through one of the sheaths, and contrast is injected so that we get an idea of how much disc material has been removed. And in this particular case, it's about 70 to 75%. And this is the AP view, confirming that we have adequate disc space evacuation within the central component of the disc space. And this, you probably can't see it that well, but this is the actual implant in place. This is the Optimesh that was inserted through one of these sheaths, and bone has been packed into this space. And you can see on the lateral view here, you can't, but it's here. The mesh cages here occupying this space, and we've got good coverage from the posterior to the anterior margin of the disc space. And what this slide shows is the initial cannulation of the pedicles at L5 and S1, and this is the guide wire that was inserted through a jam sheathing needle, and this is the initial dilator for the pedicle at S1. So these screws, these are cannulated screws. They will, once the guide wire is in place, that's 90% of the procedure for this particular part of the operation. The screws are then inserted over the guide wire, and the pedicle is prepared in the usual fashion for insertion of the screw. This is actually, screws look a little bit off, but her pedicles were off. But this is a shot towards the end of the procedure with both screws in at 5 and both screws coming in at 1. And this is the final AP view of the percutaneously inserted pedicle screws with the rods and with the interbody device. And this procedure was carried out through two 2 mm incisions posterolaterally and one 2 cm incision medially in the middle, which allowed us to insert the screws either side. So another approach, another minimally invasive approach to the spine is the lateral approach. And this really came about to kind of try and circumvent some of the issues that people ran into with an anterior approach to the lumbar spine. With the risk of visceral and vascular injury, the thinking was, how can we get into the interbody space and carry out the same type of disc evacuation that we do with an anterior approach and insert the same type of graft. And so the lateral transsciatic approach began to develop. And again, it's a minimally invasive approach to the spine, but it's being carried out now increasingly as a same-day procedure. So again, I'm just going to go through a case that we did recently, actually a couple of weeks ago. And this is a lady who was referred in who'd had a fusion at the L3-4 level, and it hadn't fused. So it was a revision case that we did, and she'd undergone a fusion several years before, 4-5 and 5-1, and she had hardware in, but the 3-4 fusion had failed. So this is a lateral view of the sheath into the L3-4 space. And with the lateral approach or the transsciatic approach, again we use AP and lateral fluoroscopic views to allow us to visualize instruments and to allow us to carry out the decompression. And this is the sheath coming down laterally onto this patient's spine. In this particular case, she had some bony overgrowth here, which we were able to remove with a small drill and some Kerrisons. It's just another AP view. This was actually more at the start of the procedure where we access the disc space and we do it with a needle, and then we put the initial dilator through. This is the interbody implant that was inserted into the L3-4 disc space, and what we did here was we inserted percutaneous pedicle screws at the L3-4 level, and we just extended the construct from 4-5 up to 3-4. And this case was carried out on a same-day basis. We had about 50 to 75 cc's of blood loss. The patient was in recovery for about 2 to 2.5 hours and was home that evening at about 8:30, 9 o'clock. And I saw her recently, and she's doing very well. Just more of this. And that was another final view of the construct with the screws at 3. These are previously inserted screws which we left in place, and the interbody device at 3-4. So I'm just going to show a little video clip of that as well. Okay, so let me see. So this is the. So I'm going to start at the beginning here. Sorry. So this is the transsciatic approach, and neuromonitoring is used in this case as we go through the psoas. These are the dilators that are inserted down through a very small incision that we make in the lateral abdominal wall. And this is the neuromonitoring clip that we attach to these dilators as they go down. And this is the guide wire that's in place. And this is the one of the final dilators. And then there's a sheath, a retractor set that's inserted over this dilator into place. And through the sheath, we're able to carry out, with the procedure, the dissection through the psoas. This was the remnants of the fell fusion. And this is a 22 millimeter portal. Now this is the cage that we're able to insert through this. Oh, and this is an MIS technique that we use for harvesting of some of the iliac crest. So we don't have to make a huge incision anymore. There's a percutaneous system that we can use that allows us to harvest iliac crest. This is a bit speeded up. We don't work that quickly. And this is we're able to collect the bone harvest, but we do it through a percutaneous, minimally invasive approach to the iliac crest. And we use this system